Hello people, in this video we want to look at this topic CoArcTaTion of the aorta. Okay, so this CoArcTaTion word, whenever you type in Google or anything, you will get only aorta only. And the way this word has originated is not there actually. So let's try to understand what is the problem that the aorta is facing here. Okay, so it is the arch of aorta which has some problem. CoArcTaTion of the aorta. Okay, so this is the disease of the aorta. So CoArcTaTion of the aorta is the disease of aorta. It is mostly congenital. It can also be acquired. Okay. So try to understand this diagram here. So here this is the heart. From the left ventricle of the heart, you're getting the aorta. In the aorta, you have three parts. Right here, you have the ascending aorta. That means which is going up like this. Then you have the arch of aorta, and then you have the descending aorta. Right. So this is the arch. Right. In this arch, ARCH is arc or ARC is arc. Arc of aorta. So you have a narrow area. So this is the coarctation of aorta. Okay. So coarctation of the aorta is the term used to describe the narrowing of the aorta where distal to the origin of the left subclavian artery. All went above head. No, coarctation of aorta is a term used to describe the narrowing of the aorta. Very well you understood, but where exactly? To distal to the origin of the left subclavian artery. So now let us understand where this left subclavian artery is originating. Okay. So now look at this. From the aorta, so we already told you ascending aorta, arch of aorta and descending aorta. See, arch is ARCH only. Okay. Now this part is right side. Okay, the right side of your body it will supply. This part is left side of your body it will supply. Okay. Now in the left you have two. What and all you have? Left common carotid artery and the left subclavian artery. So this is what we are talking about. What are we talking about? Left subclavian artery. It's not very clearly visible, but you understood, right? Left. What is this? Please, who is that? Search Microsoft guy. Left subclavian artery is here, people. So left subclavian artery, the origin is here. Distal to this origin. So this is distal and this is going to be proximal, right? So away from that origin area. So that is here. So here somewhere the narrowing is there. This here somewhere the narrowing is there. Where is the narrowing? In the arch of aorta I am saying. It is distal to the origin of the left subclavian artery. So simple, right? I'm sure you'll write this in the exam very nicely, right? Draw off this diagram also, you'll get nice marks. Okay. So coarctation of the aorta is a term used to describe the narrowing of the aorta. I'm adding this arch word, okay, but they have not said that word. Distal to the origin of the left subclavian artery. Okay. Then it is most commonly due to congenital heart disease. Mostly why is it? It is because of congenital. That means by birth some people will have this kind of problem. Okay. Then it can also be acquired in Takayasu arteritis and trauma. So they're not calling it as coarctation of aorta. They're saying similar symptoms can occur in Takayasu arteritis and trauma. Somebody punches you there. Okay. How's it going so far? So now let's move on. Okay. So look at this diagram, how normal heart is and how coarctation of aorta is. You can see here, distal to the origin of the left subclavian artery, the aorta has suffered a narrowing. Okay, so this is the coarctation of the aorta. Okay, and if you draw this diagram, you will get lot of marks, I'm sure, because with the heart you will draw, right, drawing the chambers of the heart also, and you will show from the left ventricle this aorta is coming. This will be very nice if you can draw in the exam. Move on. So the prevalence of this, how much is the prevalence of this? This is actually one of the congenital heart malformations. So you can see it is not the most common, 1, 2, 3, 4, 5, fifth most common congenital heart disease sounds like. Okay. Then this condition is more common in males. Interesting, right? It's more common in males. Okay. And 1 in 4,000 children can have this condition. Okay. Then that's all. And then what else? Some point is there here, down here. Let us look at this. Wait, go back. Okay. So what are they trying to explain here? I will try to highlight here. You see off like that only. What they're saying in Turner syndrome, that is more like a female, right? A 45X, that one Y chromosome or X chromosome is not there. So this is a female. Turner syndrome people can have coarctation of aorta. Okay. One of the clinical features can be this, but that is a female, not a male, remember. So where is this condition more common? In male, 1 in 4,000 children can have, and Turner syndrome people can have coarctation of aorta. Turner syndrome is 45X, remember. Okay. So 45X is Turner syndrome, right? Turner syndrome, right? So prevalence you got. Now very good. Now let's move on. Acquired coarctation of aorta. We already told you, following trauma or complication of this Takayasu's disease. Very good. So people, you understood, no? So now the doubt will come, what is this Takayasu's disease? No. So that Takayasu's disease is granulomatous inflammation of the vessel wall. That makes sense, right? Some inflammation of that wall made it, I think, narrow. What do you say? Leading to occlusion or weakening. Okay. So basically, why did it happen? They didn't say. Arteritis it is, right? Arterite. Okay. So granulomatous inflammation of the vessel wall. Okay. We'll not go into much details. Just say Takayasu arteritis. Okay. So this can be acquired also. Now let us look at the pathogenesis of the congenital part of it. Congenital part of it. Because acquired part, you already know what happened. Vascular vessel inflammation in Takayasu and then trauma, etc. Now let us look at the congenital. Why did it happen? Okay. Read this statement. Failure of the aorta to develop at the point of aortic isthmus where the ductus arteriosus attaches can lead to coarctation of aorta. Very good. So can lead to coarctation of aorta, we understood. Failure of the aorta to develop. Very good. Failure of the aorta to develop, that much we understood. So we have understood first and last part of it. Failure of the aorta to develop can lead to coarctation of aorta. So at which point the aortic isthmus, that you should remember, where the ductus arteriosus attaches. So this we'll understand from this diagram now. Okay. So where is this aortic isthmus? Now let us look at aortic isthmus. Here. We found it. Distal to the origin of the left subclavian artery only, this aortic isthmus is there. Okay. Let me zoom a little. So at this aortic isthmus area, okay, where the ductus arteriosus attaches, here, where this ductus arteriosus attaches, this place of this, okay, this ductus arteriosus is this part of it which is attaching the pulmonary artery to the aorta. So this part, somewhere here, you understood, right? So it is the point of aortic isthmus where the ductus arteriosus attaches, okay, and where the ductus arteriosus attaches. So this place of it. So here, at this place, aortic isthmus, you can also say the same thing. Origin of the left subclavian artery, that place, failure of the aorta to develop. I think it's all the same thing, okay? So I would say failure of the aorta to develop at the point of aortic isthmus where the ductus arteriosus attaches, or it's the same thing. Distal to the origin of the left subclavian artery. Distal to the origin of the left subclavian. Both are sounding same to me. Everything is the same place only they're pointing to. They're telling in multiple ways. So failure of this place to develop will lead to coarctation of aorta. Okay. Or probably there's this inflammation, etc. of the vessel that in the Takayasu. Okay. Next, let's move on. Very good. So let's look at this some more. Same thing they have explained. Narrowing of the aorta occurs in the region where the ductus arteriosus joins the aorta. Okay, you already know this. At the aortic isthmus, just below the origin of the left subclavian artery. Same thing they are saying. This will lead to what? Aortic what? Coarctation of aorta. Very good. Very good. So what is aortic isthmus and all? If you want, definition is there here. It is a constriction in the aorta that lies in the aortic arch before the junction with the ductus arteriosus, and it limits the flow of oxygen-rich blood to the descending aorta. So what is aortic isthmus is actually before where the ductus arteriosus joins, there is a small constriction in the aorta. Okay, this limits the flow of oxygen-rich blood to the descending aorta. So this aortic isthmus has this landmark. It is before the place where ductus arteriosus attaches, remember. So now let us go to clinical features of aorta. Okay, we mean clinical features of coarctation of aorta. Okay, now look at this. So when you just look at this now, just overall you just look at this, what will happen? What do you think will happen here? Here what will happen? The pressure will be very high. Here what will happen? The pressure will be low. So low pressure here, okay, and high pressure here. So where are these vessels going? So these will supply the head and neck, right? So these will supply your head and neck. So in the head and neck, the pressure will be more, right? And distal to the body wherever it is going. So this, let us say, will supply distal part of the body. There, what will happen? The blood pressure will be low. Okay. So here pressure will be high, and here pressure will be low. Especially, I think, in your lower limb. Now look at this, people. clinical features, there can be cardiac failure in newborn because it has to pump against this narrowing, right? But anyways, look at this overall features. What you will say, headache will be there because hypertension will be there. Head hypertension. Touch your head. Headache because blood pressure is more to the head. And what will happen to your leg? Cramps in the leg. Why? Because there is less blood pressure. Normal blood pressure or low blood pressure can be in there in the legs. So there will be weakness or cramps in the legs. Okay. So legs, what is happening? Weakness. Okay. Cramps, headache. Okay. Two things. And femoral pulses, if you check, it will be weak and delayed. Correct. So obviously, because the blood pressure here can be normal or low, the femoral pulse, right, will be weak and delayed. It can be delayed. Headache, when you check the blood pressure towards the head, right, that time there'll be higher blood pressure there. Okay, but how will you check the BP in the upper body? So now let's move on to this down part here. Okay, the systolic murmur you will hear. Obviously, you will hear it during systole of the heart because it has to push, right? The heart has to contract and push against that narrowing. So systolic murmur you will hear, and the ejection click you can hear if there is a bicuspid aortic valve. So ejection click. See, heart sounds are usually because of valves closing, right? They are because of the valves closing. So this is an ejection click. So ejection click is when the valves open. So which valve? Aortic valve. So where is your aortic valve now? See, normally it is tricuspid, correct? So here you can see this valve is supposed to be tricuspid. This is the aortic valve, but it could be bicuspid. So when it opens, it can give you obviously whenever it opens, it will give ejection click only. After S1, you have ejection click. So ejection click is coming when the valves open, that is the aortic or the pulmonary valves open. So obviously this ejection click, if you're hearing, the valves are opening, and especially they're saying you can hear it along with the systolic murmur if this valve is a bicuspid valve. So did you understand? Shall we continue? Okay. So then as a result of this aortic narrowing, collaterals can form. So some because of this there is some narrowing here, right? So blood has to flow. So what will happen? It will create some collaterals. So it will have to go like this or like this, right? So it will have to create some pathways. So they mainly involve the periscapular, internal mammary and intercostal arteries, and this may result in local bruit. Okay, so where and all it might join? It might join the internal mammary artery, periscapular artery, intercostal artery. So there might be some collaterals which form here. Okay, and these may also cause what? Localized bruit. Okay. So what and all can these people have hypertension, radiofemoral delay. That's why they ask you to always check bilateral pulses and radial and femoral together also, so that you will know if there's a delay, right? And then these people can go into aortic dissection. Now what is this? What is aortic dissection? Now look at this image here. So this is the aorta, correct? So from the left ventricle, you will have the blood coming in here, right? So blood is coming here, but what is happening? There is a narrowing in further, there is narrowing, correct? So it cannot actually go there. So the pressure here will become so high. So what it will do, it will break through the wall of this aorta, okay? And it will start flowing here. So it will start dissecting the wall of the aorta itself. So this is the aortic dissection. Okay, you understood, no? So these people will be in risk for this condition called as aortic dissection. Okay, so this is all the clinical features. So even in adolescence and adulthood, these people can have hypertension. Blood pressure will be high. Super babies, you have finished clinical features. What is left now? Only investigation and management. Okay. See, actually for this now you should read congenital heart disease topic and then you have to understand. Okay, we are covering only coarctation of aorta. So look at the investigations for coarctation of aorta. So in best is MRI. Okay, that's what they're saying. Then X-ray also you can do, but later only it will show changes, not early childhood. They are saying later it may show changes in the contour of the aorta. There will be a 3 sign in the descending aorta. Now let us understand the 3 sign. Wait, where is that 3 sign? Draw that 3 sign here. See here, I'm already seeing that. Is this the 3 sign? Twink, twink. Is this the 3 sign? I think the best is MRI. Okay, so look at MRI here. Now, in this MRI, look at the arch of aorta. Then you have the descending aorta. Between these two, you can see the narrowing. Okay. Then they are showing you this internal mammary artery, which is one of the collaterals, large internal mammary artery. Then here you can see lot of intercostal arteries which collaterals have developed. Okay, and one extra coarctation is there which is in the abdominal aorta, that we will not focus on. Okay, so MRI has shown you all these collaterals, etc. This seems to have a contrast, right? So I hope you understood that. Then chest X-ray, initially it might not show anything, but later it will show indentation of the descending aorta or 3 sign it can show you. Okay. Then ECG also it will show left ventricular hypertrophy, because obviously the left ventricle is trying to pump against this narrowing. So there could be left ventricular hypertrophy that you will notice where in the ECG. Then you can also do an echocardiography and confirm this. Okay. So what is the investigation of choice? MRI. MRI, you already saw that. In chest X-ray, what will you see? Indentation of the descending aorta. You can also see the 3 sign in the aorta. Then you will see ECG, which has left ventricular hypertrophy, and then you can also confirm all this with echocardiography. That hypertrophy, at least you can confirm with echocardiography. So how will you manage this patient? See, there's a narrowing. You have to remove the narrowing. Okay. So what they're saying is you have to surgically do something and you will have to treat it. You'll have to remove the narrowing, right? And if this keeps on recurring, then you can do a balloon dilatation and stenting. Okay. Only if it is recurring, they're telling about balloon dilatation and stenting. I'm not sure if initially they can start off with this balloon dilatation, etc. I don't know. Then better to treat early. If you do early treatment, you're not saying better done early, but if it is done early, then persistent hypertension you can avoid. Okay. Then if they have some other condition like the bicuspid aortic valve they have, then they may have again problem of aortic stenosis, regurgitation, and they will require long-term follow-up. So if they have other problems along with this CoArcTaTion, right, what is that other problem? This bicuspid aortic valve if they have, then they will have more other issues which have to be managed long-term. Okay, that's all they are seeing. That's all is the management. Okay. Now let's take a recap of the CoArcTaTion of aorta topic. Basically, this is narrowing of the aorta. So it is the disease of the aorta. It is mostly congenital. It can be acquired also, the symptoms. Now, CoArcTaTion of aorta is what? It is a narrowing of the aorta where it is the narrowing is distal to the origin of the left subclavian artery, which we have explained in detail to you already. So basically, this is mostly congenital. It can also be some similar symptoms can occur in Takayasu arteritis and trauma. Okay. Then. So this is the CoArcTaTion of aorta. You can see here, distal to the origin of the left subclavian artery, this narrowing is there. Okay. So what is the prevalence? It is one of the more happening congenital heart malformation. Okay. It is common in males. It happens in 1 in 4,000 children. And in Turner syndrome, they can have CoArcTaTion of aorta. That will be a girl. Okay. 45X actually. Okay. Then acquired condition of CoArcTaTion of aorta, why will it happen? In Takayasu's disease, which is a granulomatous inflammation of the vessel wall. And also if there is trauma, then these two conditions can lead to acquired CoArcTaTion of the aorta. Okay. Now let us look at the pathogenesis of the congenital CoArcTaTion of aorta, why it happens in these newborn babies. Okay. So basically the aorta has failed to develop where at the point of the aortic isthmus, that is where the ductus arteriosus attaches, right? Before that point. Okay. This is same point which is distal to the origin of the left subclavian artery. This we have explained in detail in this video, you can see. Okay. So exact anatomy you have understood where say that aortic isthmus where the ductus arteriosus attaches, it is it is distal to the origin of the left subclavian artery. Very good. So this place the aorta has failed to develop. Okay. Then clinical features in these people who have this condition, they will have more blood pressure, high in the head and neck, that area, upper part of the body. Lower part of the body, that is the legs and all, they will have less blood pressure. They can have normal or less blood pressure. Okay, and they'll have impaired circulation in these lower limbs, etc. So what will happen? Some of these children, they may die of they may have cardiac failure. They didn't say they'll die. They can have cardiac failure that can also lead to death. Anyways, so headache they will have because of hypertension, where in the upper part of body, and they'll have weakness in the weakness or cramps in the leg. Leg is weak, headache, remember. Okay. And when you compare this radio and femoral pulse, there can be a delay in the femoral pulse. So the femoral pulses can be weak and delayed. Okay. Then there can be systolic murmur when you hear for the heart sound. Systolic murmur can be there. There can also be an ejection click that you can hear. Okay. Because if the bicuspid valve, aortic valve has become bicuspid. Okay. There'll be a lot of collaterals which have formed here, and that can lead to localized bruit. Okay. When you hear. So basically these people can have secondary hypertension, radiofemoral delay we told you. They also are in risk for aortic dissection. Okay. Throughout life they can have hypertension. So basically if it is untreated, it may lead to cardiac failure we told you, left ventricular failure, dissection of aorta we told you, cerebral hemorrhage. So basically it can lead to death. That's what we had to highlight here. So there can be cerebral hemorrhage. Why? There's so much of blood, intracranial pressure can be high, I'm thinking, right? Okay. Then, so what investigations you'll order for these people? MRI is the investigation of choice. Okay, so in this MRI, you can see that there is this descending aorta and arch of aorta. Between these two, there is this narrowing. You can see a lot of collaterals like intercostal arteries. You can see a left mammary. This is the large internal mammary artery collateral. Okay, so that's what you can see. Then chest X-ray may be normal in early childhood, but later on, it can show that there is change in the contour of the aorta. There can be indentation of the descending aorta, a 3 sign. Okay, then there can be collaterals also that you can see in the chest X-ray they are saying. Okay, I'm thinking they have not used contrast or something, or are they using contrast in this X-ray? Okay, then coming to ECG, there can be left ventricular hypertrophy because the heart has to pump against this narrowing, and you can confirm this with echocardiography. This MRI is having contrast, right? So I'm thinking even X-ray can have contrast. Okay, then coming to management of coarctation of aorta. So basically, you have to correct this narrowing, right? So surgical correction only they are talking about. If this recurrence and all happens, then you can do balloon dilatation and stenting, etc. Okay. If you do this early, then this persistent hypertension can be avoided in these people. If they have also this condition called as this bicuspid aortic valve, if they also have this condition, then there can be more complications which will lead to aortic stenosis, regurgitation from the valve, etc. Okay, so these people will need more follow-up if they have this bicuspid aortic valve condition. Okay, so if bicuspid aortic valve is what will happen? Ejection click also you can hear. Okay, that's what they said with the systolic murmur. Okay, so this is all about coarctation of aorta we have covered. So if you want more information, you should actually read congenital diseases of heart. Okay, that's all. Bye bye.